This video presents the technique for an arthroscopic correction of a supracondylar humerus malunion in a child. We have no disclosures to make. The principal surgical indication for this technique is a supracondylar humerus malunion that results in a loss of functional motion. In addition to addressing bony malunion, this approach affords the surgeon the opportunity to address an intracapsular contracture concomitantly. Contraindications for this technique revolve around exposure. If arthroscopy does not improve exposure, the procedure should be abandoned in favor of a traditional open osteotomy. Also, this approach demands an experienced elbow arthroscopist, comfortable with pediatric elbow arthroscopy. Lastly, if there has been prior ulnar nerve transposition, we find that elbow arthroscopy is generally contraindicated. Herein, we present an illustrative case of our technique in an 8-year-old child. The patient had a range of motion of 10 to 100 degrees preoperatively. These figures demonstrate the sagittal plane deformity with the fracture healing and extension. The contralateral side is supplied for comparison purposes. Non-depolarizing general anesthesia and a scaling block are generally utilized during this technique. We place a non-sterile tourniquet high on the arm, out of the operative field. We routinely position elbow arthroscopy patients in the supine position using an adjustable shoulder positional such as the McConnell arm holder. This allows the patient's arm to be placed either across the chest or at the patient's side, conferring multiple advantages: the ability to move the arm in space, easy access for fluoroscopy, easy elevation of the arm to minimize breakthrough bleeding, and application of longitudinal traction of the arm. The posterior compartment is accessed with the arm across the patient's chest, and the anterior compartment with the shoulder abducted 90 degrees and the humerus parallel to the floor. Critical landmarks, including ulnar nerve, median and lateral epicondyles, radial capitellar joint, and the olecranon, are marked. Just as in adult elbow arthroscopy, the pediatric elbow is highly constrained with extensive surrounding neurovascular structures. Unlike the adult elbow, there is even less margin for error. Therefore, the pediatric elbow joint is insufflated with 8 cc's of saline to distend the capsule and displace the critical neurovascular structures away from the joint. As in adults, all portals are established with the elbow in 90 degrees of flexion to minimize the proximity of the neurovascular structures. Portals are made close to the capsular insertion on the supracondylar ridge to prevent entrapping capsular tissue between the portal and the humerus, which would decrease the joint volume and compromise exposure. Lastly, we only incise the skin. No stab incisions are made. This is followed by blunt dissection through the subcutaneous tissue down to the level of the capsule. This helps to minimize the risk to the surrounding structures by displacing them out of the proposed path prior to trocar insertion. All trocars are blunt tipped. During arthroscopy, infusion pressures below 20 millimeters of mercury are used. This permits extending working time without distending the elbow. A proximal anterior medial portal is created using blunt trocar technique. This portal is often used as a starting point in elbow arthroscopy and offers an optimal view of the entire anterior compartment. It is made 2 centimeters proximal and 1 centimeter anterior to the medial epicondyle to avoid injury to the ulnar nerve. When making the portal, a blunt trocar should be used to pierce the flexor pronator mask. The trocar should be slid along the anterior surface of the humerus, aimed towards the radial head. During this portal placement, the structure most at risk is the medial antebrachial cutaneous nerve. A 2.7 millimeter camera is then inserted via this portal, and the remaining distal, proximal, and anterolateral portals are created under direct vision as needed. Once proper visualization is achieved, the joint is inspected to determine whether an arthroscopic osteotomy would achieve the desired effect. Here we demonstrate that when the elbow is flexed to approximately 115 degrees, the radial head is no longer articulating with the capitellum. An osteotomy would correct this malalignment. Next, a 3.5 shaver is utilized to perform the initial debridement, taking care to direct the instrument away from the capsule and radial nerve. The shaver is then used to clear the anterior humerus of scar tissue and adherent capsule. We then make proximal anterolateral portal to facilitate the osteotomy. The anterior apex of the deformity is visualized through the arthroscope and marked. A mini C-arm is brought into position to confirm the optimal site of osteotomy is marked and corresponding to our previously templated position. Then a 4 mm burr is used to create a transverse anterior trough across the distal humerus at the supracondylar level. Interval radiographs are obtained to monitor the progress of the osteotomy. The instruments are exchanged between medial and lateral portals to facilitate the bone cut, taking care to leave the posterior cortex intact as a hinge. Once sufficient bone has been removed to perform a closing wedge osteotomy, the distal fragment is flexed forward and the line of the anterior humeral cortex is aligned to match the contralateral elbow. 3 2 mm K-wires are inserted under radiographic control, 2 lateral and 1 medial, taking care to avoid the ulnar nerve. At this point, elbow flexion and extension is analyzed. If a preoperative examination revealed a flexion contracture, then an arthroscopic contracture release is performed. Of note, routinely performing an in situ ulnar nerve release is often indicated when performing a flexor contracture release. If, preoperatively, there is no true flexion contracture noted, but the patient is still lacking extension during surgery, then a contracture release will be performed. It is important to explain this to patients preoperatively so that they may consent accordingly. At the conclusion of surgery, the elbow is flexed and extended to examine the carrying angle and radiographic verification of alignment achieved. The portals are closed with interrupted 6-0 plain gut sutures. The pins are trimmed to an appropriate length, and the arm is placed in a well-padded long plaster cast with the elbow flexed at 90 degrees and the wrist in neutral. We do not routinely bivalve our casts. At 8 weeks follow-up, the patient has regained a remarkable range of motion with a mild flexion contracture. At 12-month follow-up, the patient has a normal range of motion and the operative arm is barely discernible from the non-operative side.